Sarath Sivan to talk on intraocular lens selection and surgical techniques for combined cataract and retina surgery.
Thanks, Dr. Harshali. Today I'll be dealing with IOL selection and surgical techniques in combined phaco-vitrectomy. Initially, phaco-vitrectomy was considered in cases with very significant cataract interfering with the viewing of the retina during the surgery. But nowadays, as the confidence in the procedure increase, we are performing combined vitrectomy for even cases with very minimal lens opacities and even clear lens, so that patient can avoid a subsequent surgery and to just fasten the visual recovery. This is termed as a non-essential phaco-vitrectomy. Besides this, doing a combined approach helps in removal of the complete anterior vitreous and helps to do a complete base dissection without any fear of lens touch. This is important in cases with reg RD with multiple breaks and in diabetic vitrectomy to prevent any anterior hyaloid proliferation. Also, doing a complete vitrectomy allows for a better gas fill and this results in a good tamponade. Coming to the IOL power calculation, our primary aim is not to achieve emetropia but to settle the vitreoretinal pathology. But now we are able to give excellent result with use of optical biometry and new generation formulas. All of the formulas give excellent result in doing combined vitrectomy. It's always better to avoid multifocal IOLs because the multiple rings in the IOL can create focusing issues. Coming to the material, always acrylic hydrophobic material are preferred over hydrophilic or silicone IOLs. Because if you use a silicone IOL or hydrophilic IOL, it can lead to very dense condensation of over the IOL while doing the fax when the posterior capsule is cut open. And also if the chamber is filled with oil, this oil can get stuck to the IOL material and it is completely difficult to remove it completely. So always hydrophilic, acrylic hydrophobic material are preferred while doing the combined surgery. There is a study published in Journal of Cataract and Refractive Surgery. It's comparing single piece IOL and multi-piece IOL while doing combined phaco-vitrectomy. The results show that incidence of optic capture and posterior synaptic formation is more common with single piece IOL than with multi-piece IOL. Single piece IOL, the optic size is smaller, so it can easily get displaced from the back while doing a fax or with gas tamponade, especially when the rexus size is larger. Whereas the 3-piece IOL optic will be larger in size, so it will be more stable inside the bag. There is less chance for displacement. So always, if the rexus is larger, it's better to go for a multi-piece IOL. Coming to the surgery techniques, incision, you can either choose a temporal phaco or a superior phaco. The advantage with superior phaco is that surgeon doesn't need to change the position in between the surgery. And doing a good rexus is very important while doing combined phaco-vitrectomy. The rexus size should be adequate. It should be covering 0.5 to 1 millimeter of the optic margin. If the rexus is large, there is a chance of IOL get displacing from the back. Sometimes in cases with very dense VH, doing a rexus without a red glow, doing a rexus will be difficult. Such case you can stain the capsule nicely with trypan blue and complete the rexus. The size is very important. Rexus size is very important. Then coming to the phaco part, you should keep in mind that you should have a clear cornea till the end of the retina procedure. So you use very minimal ultrasound energy. To protect the corneal endothelium, you can use dispersive viscoelastic, and emulsification, you stay in the pupillary plane and do the emulsification. So that at the end of the surgery, you will have a clear cornea. Completely remove the nuclear material. Whichever technique you are using, either stop and chop or direct chop, you use minimal ultrasound energy and complete the procedure. And cortex wash, in dense VH case without red glow, cortex wash may be difficult. Carefully remove all the cortex. Sometimes if some peripheral cortex is left behind, that can interfere with your retinal viewing. So completely clear the cortical matter. Then IOL implantation, already I have discussed. You can, if the rexus size is adequate, you can always go for a single piece IOL. If you feel the rexus is larger in size, you go for a multi-piece IOL, especially when you are going for a gas tamponade. It's better to go for a multi-piece IOL. Then while do the visco wash thoroughly. Make sure you completely clear the anterior chamber. Sometimes small air bubble can be there in the anterior chamber that can affect your retinal viewing. So always make sure you completely remove the all tiny air bubble in the anterior chamber. And while closing the wound, make sure your anterior chamber is well formed. And always you need a watertight wound. Hydrate the side port and main port, but never overhydrate the wound. Overhydrating the wound can cause a cloudy cornea and affect your retinal viewing. So you should never overhydrate the wound. If you feel that wound is leaking, never hesitate to put a suture. And inserting the trocar cannula, insert the cannula without giving much pressure to the eyeball. You can insert the cannula with a screwing motion, you can go inside. If you do like this, your pressure over the eyeball will be minimal. If you give pressure on the eyeball, your chamber can collapse. So it's better to go inside with a screwing motion. In between, if the chamber get collapse, you can hydrate the side port, form the anterior chamber, and then proceed with the inserting the cannula. Now you can safely cut the anterior hyaloid without any fear of lens touch. While cutting the anterior hyaloid, it is better to keep the cutter facing sideways or downways. With this, you will avoid the cutting the capsule. In between the surgery, sometimes cornea can get hazy. There can be epithelial edema. Such case, you can peel off the epithelium, or as I mentioned, you can use topical glycerin. Then your viewing will become much better, and you can easily continue the surgery. And always before ending the surgery, before doing a fax and going for a tamponade, always check the anterior chamber, whether anterior chamber is formed, whether IOL is in position, then go for gas and tamponade. So the combined approach, combined phaco-vitrectomy is excellent technique to fasten the visual recovery. If well planned and executed, can give wonderful results for the surgery. Thank you.